The HINTS Plus exam in vertigo. This video will describe who to perform the HINTS Plus exam on, how to perform it, and how to interpret the findings. The HINTS Plus exam should be performed when a patient presents with many hours or days of ongoing constant vertigo, nausea and/or vomiting, and some difficulty walking. Their vertigo gets worse with head movement, such as going from lying to standing or turning their head. Importantly, you can observe nystagmus, either spontaneous when they are looking straight ahead, or a gaze-evoked nystagmus when you ask them to look to the left and right. Most of these patients will be suffering from vestibular neuritis, a benign peripheral cause, but some will be having a stroke. The HINTS Plus exam is used to reliably diagnose vestibular neuritis and thus rule out a stroke. There are 4 components to the HINTS Plus exam: nystagmus, test of vertical skew, the head impulse test, and a bedside test of hearing. The plus part of the HINTS Plus exam is the addition of a bedside test of hearing. It was added to the other 3 components as a particular kind of stroke, an ICA stroke, which stands for anterior inferior cerebellar artery stroke, can produce an infarct not only to part of the cerebellum, but also to the ear's labyrinth, where the sensory end organs for hearing and balance reside. And so an ICA stroke can result in an abnormal head impulse test and acute hearing loss. The bedside hearing test will pick this up as being a central vertigo. Spontaneous nystagmus is observed with a patient looking straight ahead, also called primary gaze. Gaze-evoked nystagmus is observed when you have the patient look to the left and right. This normal volunteer has no nystagmus in primary gaze. When you ask your patient to look off to the left and right, don't ask them to look at your finger, as fixation can suppress nystagmus, especially when the cause is a peripheral one, such as vestibular neuritis. When you fixate on something, you are asking your eyes to not move, so that the image is well stabilized on your retina and you can see it well. It doesn't make sense to ask the patient to not move their eyes and then look to see if they have any abnormal eye movement. Instead, to remove fixation, you can take a blank piece of paper and place it close to the side of the patient's head and ask them to look through it as if it wasn't there. This may allow you to see nystagmus, which was not visible on primary gaze or when they were fixating on an object. In this patient with vestibular neuritis, observe his left beating nystagmus. When he looks to the left, his nystagmus increases in intensity and frequency. There's also a rotatory component with the upper poles of his eyes beating towards the left. When he looks to the right, his nystagmus lessens in frequency and intensity, but the direction of the nystagmus is still to the left. So it's unidirectional nystagmus, and this is indicative of a peripheral pattern of nystagmus. Compare that to this lady. When she looks to the right, she has small amplitude but abnormal horizontal nystagmus with a fast component to the right. When she looks to the left, you can see her nystagmus is now beating towards the left. So she has direction-changing nystagmus or bidirectional nystagmus, and that is a central pattern of nystagmus. Not every patient with a central cause of their vertigo will have this pattern of nystagmus, but if they do, it is highly specific for central vertigo. The test of skew is observed by doing the cover-uncover test. You simply take your hand and place it so that you are blocking the vision of one eye, then move it to cover the other eye. Hold your hand far enough away from the patient that you do not touch their face. Observe if there is any vertical movement of the eye when it is uncovered, either purely vertical or vertical diagonally. In this patient, observe when I first uncover his right eye, the right eye moves medially and upward, and when the left eye is uncovered, it goes medially and downward. It gets a little less as we go along, but there's definitely some vertical skew deviation, which is a HINTS Plus central result. The head impulse test will be abnormal in vestibular neuritis. The head impulse test is looking to see if you can demonstrate a nerve problem. If the patient has a nerve problem, they probably don't have a brain problem. This is where a lot of people get hung up on, because it's counterintuitive that an abnormal finding is reassuring. To perform the head impulse test, Hold the patient's head so that you have a firm grasp of the skull. Have the patient look at your nose or camera and move their head back and forth until their neck muscles are relaxed. Then, in a random fashion, move their head briskly to the midline. The head only needs to be turned 20 degrees off midline to the center. This movement should be performed as quickly as possible. You're looking to see if there's an abnormal catch-up saccade, which would indicate a nerve problem. In a normal person, such as this volunteer, the eyes should remain fixed on your nose even when the head is turned briskly to the midline. This is a normal vestibulo-ocular reflex. If this were a patient with hours or days of constant vertigo and nystagmus, this would be a worrisome finding. In this man with vestibular neuritis, when his head is turned to the left, there's a normal response. But then when his head is turned to the right, you can see a larger movement of his eyes. This is the abnormal catch-up saccade, which is reassuring for a peripheral cause of his vertigo and nystagmus. Another one with the head turned to the right, an abnormal catch-up saccade right there. Turn to the left, it's normal. Turn to the right again, another abnormal catch-up saccade, indicating a peripheral cause. This lady, whom we saw earlier with the concerning finding of bidirectional nystagmus, she is a completely normal head impulse test with no catch-up saccade whatsoever. This is worrisome as she had had days of vertigo and nystagmus, and we can't find a nerve problem with the head impulse test, so she probably has a brain problem, which she did. Finally, the plus part of the HINTS Plus exam is the bedside test of hearing performed by the finger rub test. As discussed earlier, an ICA stroke can produce an abnormal head impulse test, which usually is a reassuring finding that the patient has only vestibular neuritis. But with the ICA stroke, the patient also has acute hearing loss occurring at the same time. The finger rub test will pick this up. Simply rub your fingers against each other close to the ear and ask the patient if they can hear it. If the patient feels they are not hearing as well in one ear, and this is a new finding for the patient, this indicates the possibility of a central cause of their vertigo, possibly an ICA stroke. So for a HINTS Plus exam to indicate a reassuring peripheral result, you have to have all of the following: unidirectional nystagmus, no vertical skew, an abnormal head impulse test, and normal bedside hearing test. A HINTS Plus exam which is worrisome for a central result is when you have any of the following: bidirectional nystagmus, abnormal test of skew, a normal head impulse test, or any new hearing loss. To recap an important point regarding bedside testing of patients with vertigo, which patients do you perform the HINTS exam Plus on? Only patients who are having constant ongoing vertigo for hours or days and they have spontaneous or gaze-evoked nystagmus. So here's a last question for you. When do you perform the HINTS Plus exam and the Dix-Hallpike test on the same patient? Well, we just said that the HINTS Plus exam should only be performed on patients with hours or days of constant ongoing vertigo and they have spontaneous or gaze-evoked nystagmus. For the Dix-Hallpike test, it should only be performed on patients who have short episodes of vertigo, which are initiated by head movements and last typically 30 seconds, but certainly less than 2 minutes. And importantly, they have no spontaneous or gaze-evoked nystagmus. So the answer to the question is never.